Intratympanic glucocorticosteroid therapy for idiopathic sudden hearing loss. Background and objective: glucocorticoids are the standard treatment for idiopathic sudden sensorineural hearing loss, ISSNHL, but whether intratympanic or systemic therapy is superior remains controversial. Previous meta-analyses of this question have omitted key clinical trials or included observational studies. Methods: English language randomized controlled trials in OvidSP, PubMed, Embase, CINAHL, and the Cochrane Library comparing intratympanic versus systemic glucocorticoid therapy for ISSNHL were meta-analyzed using RevMan 5.3. The primary outcome of interest was improvement in pure tone average, PTA, threshold. Results: 6 trials involving 248 patients receiving intratympanic steroids and 236 receiving systemic steroids were meta-analyzed. PTA thresholds were similar between the two groups at 3 months after therapy initiation. Mean difference, 0.24, 95% confidence interval, -2.43 to 2.91. P equals 0.86, I2 equals 54%, P equals 0.07, random effects model. PTA thresholds were also similar at 6 months, mean difference, 4.69, 95% -5.84 to 15.22, P equals 0.38, although the results showed extremely high heterogeneity, I2 equals 98%. Sensitivity analysis indicated that a single trial containing 250 patients provided the strongest evidence for equivalence between the two types of therapy. Rates of recovery within 3 months, defined as PTA improvement 10 decibels, were similar between the two types of therapy. Odds ratio 0.92, 95% to 0.59 to 1.43, P equals 0.70. With no significant heterogeneity in the pooled data, I2 equals 1%, P equals 0.40. Conclusion: intratympanic and systemic steroids therapies appear to show similar short-term efficacy for restoring hearing in patients with ISSNHL. Intratympanic therapy may reduce systemic side effects associated with steroid use. Idiopathic sudden sensorineural hearing loss, ISSNHL, defined as hearing loss of greater than or equal to 30 decibel in 3 consecutive frequencies of pure tone average, PTA, within 72 hours, 1, is estimated to affect 5 to 20 people per 100,000 per year worldwide. 2. The causes of the condition are unknown but are more likely to be a spectrum of pathologies that affect the cochlea, rather than a single pathological change. 3. Primary treatment and interventions for this condition are the subject of ongoing debate, which is made more complex by the fact that 32% to 65% of patients spontaneously recover within 15 days from onset. 4 to 7, among the numerous treatments tested, 8, oral, systemic steroid treatment is the most frequent primary treatment and is widely considered the most effective. 9. However, systemic steroids are associated with significant side effects, including mood changes, loss of appetite, disrupted sleep patterns, increased thirst, weight gain, hypertension, and hyperglycemia. Therefore, this therapy should be considered carefully if patients have other chronic diseases, such as diabetes mellitus or glaucoma. 10. An alternative to systemic therapy is intratympanic therapy, first proposed by Silverstein et al. In 1996. 11. Local steroid administration directly into the ear reduces the risk of systemic side effects and allows the steroid to penetrate directly into the cochlea and achieve a high concentration there even when low doses are used. 12,13. Steroids administered at the tympanic membrane are usually dexamethasone and salumedrol, which affect immune suppression and ion homeostasis. 14. The principle behind this therapy is that the steroid reduces inflammation associated with labyrinthitis, enhances cochlear blood flow, and improves stria vascularis function. 15. In fact, Intratympanic therapy can be an effective second-line therapy for patients who do not recover hearing after oral steroid treatment. 7,10,15-20. Despite its advantages, intratympanic steroid therapy is more expensive, requires multiple office visits, and is associated with pain, transient dizziness, infection, and persistent tympanic membrane perforation. 1. The evidence base is unclear on how intratympanic or systemic steroid therapy compare as primary treatments for ISSNHL. Some studies have found the two to be equivalent, 21,22, while others have found intratympanic therapy to be superior, 23-25, while one meta-analysis 26 concluded that intratympanic therapy is superior to systemic therapy. Other meta-analyses have found the two types of therapy to be equivalent. 18,27,28. At the same time, some work has shown intratympanic administration to be inferior to combination therapy involving intratympanic dexamethasone and high-dose prednisone taper. 29. These discrepancies in the literature prevent definitive conclusions about the optimal primary treatment for ISSNHL. Since these discrepancies are likely due to inclusion of studies that were not exclusively randomized clinical trials, RCTs, and of studies in which patients were treated with combination therapies, we wish to review and meta-analyze relevant evidence only from RCTs comparing intratympanic and systemic steroid therapy as single therapies, not in combination with other treatments. RCTs can provide the most rigorous assessments to guide clinical practice. 30.